Thank you so much for being here. We've got a pretty good agenda tonight. We've got moderators here. We have a great panel who will be introducing themselves very shortly. And so I think we should get going. I believe that all of us are here for a reason, a very good reason. We all recognize the significance of what I call an epidemic, a crisis. I don't know how to say it any clearer. We are in trouble. Our youth are in trouble, and I'm very, very disturbed by the statistics. I have put together a handout here, and I would hope that all of you will take it home and take a good look at it. And what I would really like from all of you is feedback. So we are going to close out tonight's forum with some remarks that I think some of you will be very interested in. But before going through any of that, I'd first just like to listen to the panel, to the questions, to everyone's thoughts and concerns about where we are. And then the city is going to take the lead, working with different groups to form a task force, and I think it'll be a very strong task force, and I think it's going to be very beneficial to this community. But I will open by saying this to you all. Since July 1st of 2015, the city of Waterbury responded to 359 overdoses. 359. Out of those 359, 164 cases were handled with Narcan. So Narcan was deployed 164 different times since July 1st. Okay? We have a problem. You all know about it. It's been reported now nationally, but here in the city of Waterbury in particular, we have seen, I went on the police department in 1980, and we dealt with heroin epidemic back in the 80s and early 90s, and then it really subsided to a great degree. The last 3 years have been staggering, the increases in the use of heroin, and I think you all know why, but we'll let the panelists give us their ideas, and certainly we're here to listen and learn. At the end, as I said, we'll close it out with some informational background on where we're going to go next. But just to I will take a moment to thank each one of our panelists for their contribution tonight. But this will be the first of other meetings to follow with different fields of expertise and the follow-up meetings in addition, of course, to tonight. So thank you, each and every one of you, for being here and your interest on this issue. And again, I can't tell you enough how important your feedback will be subsequent to tonight's forum. Thank you.
Thank you, Mayor O'Leary. I'd like to take a moment to, first of all, mention to those of you in the back, there are plenty of seats up front, or is this like church where nobody takes the seat up front? Please make yourselves comfortable and take the seats. That will give you a good vantage point. I'd like to begin this evening by giving appreciation to three people who've been incredibly instrumental in bringing this evening about. Mayor O'Leary, with his leadership and willingness to take this on, I think is really wonderful. My colleague Jennifer DeWitt, the director of the local, the CNV Regional Action Council, and her incredible leadership in this area. I think she really deserves a lot of appreciation. And the mayor's chief of staff, Joe Geary, standing quietly in the back, was wonderful in helping to pull this together. So let's hear it for the folks who pulled it together. And my name's Janine Sullivan-Wiley. I'll be the moderator this evening. I'm the director of the Northwest Regional Mental Health Board, and we serve Waterbury and the other 42 towns of northwestern Connecticut. and I'm just absolutely honored to be able to be here tonight. So I'm going to ask our panelists to take a moment to give us a quick who they are and why they're here tonight, and then we'll return for them to give further description of some of the issues as they see fit. So.
Hi, good evening, everyone. I'm Commissioner Miriam Delphin-Rittman. I'm from the Connecticut Department of Mental Health and Addiction Services. And I'm here this evening to share information about services and supports and different initiatives that Demas is a part of, but also to hear from all of you about your concerns, questions, comments, things you feel that are working well, things that aren't working well. I think gatherings and conversations like this are so important, and so I appreciate everyone coming out this evening, and also appreciate Janine and the individuals who helped to convene this forum. So thank you, everyone, for coming out.
Thank you, Jean. Name is Jonathan Harris. I am the Commissioner of Consumer Protection. I want to thank the Mayor and Chief of Staff and everybody for being here. And you say consumer protection, why am I at this table? Well, we are working to collaborate not only with our sister agencies, but with law enforcement and other community groups, because we oversee drug control in the state of Connecticut. We regulate all pharmacies and pharmaceutical companies, and I'd like to tell you a little bit about some of the pieces that we're working on in the collaborative effort to end this epidemic, and also really hear from you and answer your questions about our role. So thank you.
Good evening. My name is Vernon Riddick. I'm the Chief of Police in the City of Waterbury. Obviously, from a law enforcement perspective, we're here to promote the safety and security of all of the citizens and those victims involved with this epidemic. And we're here to assist and promote education, and as well as learn from you what we can do to assist. Thank you.
Good evening. My name is Peter Jacoby. I'm the chairman of the Department of Emergency Services at St. Mary's Hospital right here in Waterbury, also the medical director for Fire EMS, and here to represent the medical community to tell you how strongly we support the measures of ending opioid abuse, the writing of prescriptions, and later when I get the chance, because there are many colleagues in the audience of mine who agree 100%. I recently spoke to the newspaper here in town talking about what the CDC's guidelines were which were just published last month. And to tell you just very quickly, almost all of us, or I should say all of us, support this 100%. And that's the American College of Emergency Medicine, the Connecticut State Medical Society, the Waterbury Medical Society, and every one of us who deals in writing prescriptions every day are behind this 100%. Anything we can do to decrease the number of opioids out on the street and save lives, and then help those that are already addicted, we're behind you and we're working with you.
Thank you, Doctor. Again, I'm Neil O'Leary, and I'm the mayor, and I'm here really to listen and learn. Thank you.
Good evening. My name is Rob Lambert, and I'm the Executive Director of Connecticut Counseling Centers. And I'm here primarily to give you the perspective of a treatment provider in terms of what we're seeing, what we have been seeing in terms of treatment trends, as well as what we see the current needs of the community. Also going to share a little bit regarding what we in the field feel are necessary for a comprehensive community response, and some of the factors that I believe that we as a group need to focus on in order to adequately address this epidemic. And like the other panelists, I'm really anxious to hear from you. I've been fortunate enough to be able to attend a couple of forums around the state regarding the opioid epidemic, and I have to say I'm really impressed with the turnout here tonight. I want to thank all of you for taking the time to be here, because this is an epidemic and it's going to require community response. And so I'm really looking forward to speaking with you.
Hi, My name is Lee Early. I am here as the face of an addict in recovery. I'm 9 years sober from a many-year opiate, very serious addiction. So I'm just here to offer some hope and try and learn with the rest of you.
Good evening. My name is Jennifer DeWitt, and I'm the Executive Director of the Central Naugatuck Valley Regional Action Council. We support substance abuse prevention as a partnership of 13 regional action councils across the state, otherwise known as the Connecticut Prevention Network. We work under the Department of Mental Health and Addiction Services Prevention Unit to support local level prevention. My service area is Waterbury and the 11 surrounding communities. I work closely with our local prevention councils, chief elected officials, chiefs of police, schools, parents, youth groups in each of my towns. And I'm here also to listen and to share with you some prevention strategies that hopefully you can leave here with this evening. Thank you.
Thank you to our panelists, and I note again, we've got some seats on the side and the front. I also see here in the audience a number of people from law enforcement, from various other communities, specialists in the field, mental health and substance abuse treatment providers, and I'm quite certain people in recovery, more people in recovery and their family members. So I'm really looking forward to a wonderful conversation, and this isn't just hearing from them, because I'm quite sure, with due respect to our panelists, that there's equal expertise here that I'm hoping you'll all share. So with that, thank you. And our first panelist, Commissioner Miriam Delphin-Rittman. And I believe you're speaking about what's operating at a state level, some of the new laws and policies, and what DEMAS, so if she mentions DEMAS, that is the Department of Mental Health and Addiction Services, what they're doing. Commissioner.
Yes. Yeah, so I'll start by letting you know a little bit about DEMAS for those that aren't familiar with our scope and our areas of work. So DEMAS, again, Connecticut Department of Mental Health and Addiction Services, we, in many ways, are the safety net agency for prevention, mental health, and addictions statewide for individuals who are underinsured or uninsured, who are on Medicaid. We offer a range of mental health and substance abuse prevention services. This has been an area that, addressing the heroin and opioid epidemic and crisis is an absolute priority for us. There are a range of services we offer, including detox, including residential, outpatient services, recovery supports. We also offer medication-assisted treatment, so methadone, buprenorphine, Vivitrol, depending upon an individual's where they are in their recovery journey. So we offer services in all areas of the state, and so that's an area that we are continuing to prioritize. In terms of resources, probably about $123 million or so that we, for addiction services, and then about $80 million or so through Husky D. So Connecticut is really richly resourced in terms of being able to provide a range of services for individuals. We also have a call line, a 1-800 number that we went live about 3 or 4 weeks ago. And this is something that we feel is really important, that we want people to know about. I have posters that are in the back that I want people to take copies of, disseminate them, put them up. Essentially, this 1-800 number will link people to any one of, we have about 45 or so, and the number is growing, of walk-in assessment centers, where somebody can go in, receive an immediate assessment, and be linked to the appropriate level of care based on where they are in their recovery or their addiction challenges. So they can be linked with detox, with residential, with outpatient services, with recovery support services. And this number is 24 hours. It's 24 hours, and individuals will be linked with services, whether they have private insurance or Medicaid or no insurance. So it's really for anybody. And so we're really asking people to help us disseminate information about that number. So that's one area of work that we have going on to address the the heroin and opiate crisis that we're seeing in the state. We've also are in the process of implementing, in many ways, a three-pronged approach. So we're doing a lot of work in the area of prevention, in terms of treatment, and then in terms of recovery and ongoing supports for folks. In terms of some of our prevention work, one area that we've been focusing on is really trying to help individuals have more information and awareness about the importance of getting rid of or giving back unused medications. Some of the research suggests that of individuals who are addicted to heroin, about 70% or so started from prescription painkiller use. So we do a lot to advertise drug take-back days, but also where drop boxes are. Many police departments across the state have drop boxes that are available where individuals can drop off unused medications. And some of the numbers in terms of the pounds of unused prescription medications that are being dropped off at the police departments are pretty significant. So we do a lot to advertise those drug take-back days and drop boxes. There actually is going to be a drug take-back day April 30th. And so we're helping to disseminate information about that. And again, this is an opportunity to get rid of unused prescription medications, because often those, for many individuals, are what contribute to their heroin and opiate use. Some of what we're finding is that as heroin and opiate, it's cheaper, the heroin. And so individuals may start on prescription medications or prescription drugs, but then often switch to heroin because it's really just cheaper than the prescription medications. Other areas of work that we have going on, we have a collaboration with Department of Corrections, where we're looking to continue individuals who are arrested and are on methadone, giving them the opportunity to continue with methadone while they're in prison. And that reduces the likelihood of binge use when they're released, reduces the likelihood of potential overdoses when they're released. So that's a collaboration we have going on with the Department of Corrections and looking to scale that up as possible and as we're able to do that. We also have an Alcohol and Drug Policy Council that I chair with Commissioner Katz from the Department of Children and Families. Essentially, that's a council that it's a statewide council. Many other commissioners, Commissioner Harris is part of it, many other commissioners. We have individuals in recovery, family members, first responders, community members, and essentially the aim and charge from the governor is to come up with policies, strategies, recommendations around addressing the trends and patterns that we're seeing in relation to the heroin and opiate crisis in the state. It's an opportunity to collaborate and to put structure on the range of activities and range of initiatives that are happening statewide. I don't want to go on and on because this evening really is about the conversation and discussion, but just a couple more things that I think it's important for folks to know about. There is increasing legislation around increasing the availability, and Commissioner Harris, I believe you'll be speaking about this as well, but a lot of work in the state around making Narcan more available. And that is, as many folks know, an overdose reversing drug, and that's becoming increasingly available through pharmacies, and I believe you're going to be talking about that as well, so I won't go. But a lot of work going on around in terms of Narcan. And I'll stop there because there's time for questions and discussion, and really looking forward to any questions and comments that you have. So thank you.
Thank you, Commissioner. And I'll comment, and I'll do this as it's going along. I see some of you are really interested in having the information. There is a flyer out on the table, so some of you may have grabbed things on the way in. If not, catch them on the way out. There's a flyer that says exactly where the drop boxes are around here, so you can grab that if you're interested in medication drop box. And you'll also find these lavender-colored resource sheets. One of the things on them is that 1-800 number that the Commissioner referred to, and I'd encourage everybody to take one. Our board does these every year as resources. They list mental health services, substance abuse services that are available in the greater Waterbury area, and these are updated as of this afternoon. So you should find those pretty current. So thank you. And Commissioner, you came in under 7 minutes, so pretty good.
did I? See?
The gauntlet is down. All right. And next we have the Commissioner of the Department of Consumer Protection, Jonathan Harris, who will be talking about prescription monitoring system, Narcan, fake scripts, I want to hear about that, and provider and patient education. Commissioner Harris.
Thank you, Jean. It's actually very fitting that I follow Commissioner Delphin Rittman because we are partners along with the Department of Public Health and some other sister agencies. And as I look across the room too, that type of collaboration, I mean, you see different people, different walks of life, different uniforms, some suited for battle like me in ties and otherwise. And that's really what it's going to take, is that type of community, public, private, all levels of government really attacking this from as many angles as possible. So I appreciate that. And I just want to say also that I come here wearing an official hat, but I have been personally affected. 5 years ago, this June, my brother-in-law David died of an overdose. And we miss him terribly. And I also had a cousin from New York, a 23-year-old that seemed to be doing fine, who passed away within the last year also from an overdose. So I feel it not just from a policy and regulator's perspective, but from that perspective too. And so I'm going to touch on a couple of things, and you can see the overlap because we can both talk about these programs because we do work on them together. And that's an important thing. The prescription drug monitoring program, 1, 2, drug disposal, and 3, access to naloxone. Those are the main points, and I'll just give you a little overview and then entertain any questions or suggestions or comments that you have. The prescription drug monitoring program, the PMP, was passed by law in 2006. Became fully operational public in July of 2008, and it really is a tool for doctors, other healthcare professionals, pharmacists to make sure that their patients have the best medical program, the best medicine available for treatment. And I want to start off by saying it has like this focus now of being a tool in fighting the opioid epidemic, which it does and it is. But people also have to remember that it's an important electronic medical record for healthcare professionals to be able to treat patients. So it's not just about the epidemic. We have to be careful when we're making decisions on what to do with it, how to make it better, not to interfere with that other purpose of treatment. You might, in this day and age, someone might have several different medical professionals that they go visit, each prescribing something different for a different condition. It's very important that all of those professionals have a complete picture of the patient's prescribing history, not just to identify problems, addiction, doctor shopping, diversion, those important pieces, but also one of the drugs might interact differently with one of the others, and maybe that will affect treatment. So that snapshot, that picture of someone's prescribing history is important. All Schedule 2 to 5 drugs are entered in the PMP by the pharmacist when dispensed, and as of last year, doctors, when they prescribe, or other prescribers, APRNs for example, when they prescribe over a 72-hour amount of a drug, are required to look up the patient in the PMP to make sure they see what's going on. Law enforcement also has access to the information on the PMP as it may be related to the particular case. They actually have to have a case number that you'll probably hear about from the chief that they have to use when they sign in. The PMP has an alert feature that can be used to send out alerts regarding specific patients. There are quarterly reports that flag patients. So again, things that kind of ticklers to help make sure that the professionals are engaged. So it really is a very good tool to help identify patients that are at risk and also help prevent diversion, doctor shopping, etc. Drug disposal. It's really important, as was mentioned by the commissioner, for families to safely dispose of their drugs. Whether it's kids, you used to hear about these parties, I think they call them farming parties, and they'd raid the drug cabinets, or just having extra medication around that minors or other family members have access to. It's a huge source of getting prescription drugs and of addiction is that type of just medication that's out there. So we help operate the drug collection program. We have 60 boxes, as was said, at police stations throughout the state. We also are out there trying through outreach and education to make sure that families know how to dispose of medication, that you can actually take things like coffee grounds that are kind of nasty smelling and pets and kids won't want to eat, and dilute the drugs, chop them up, put them in with these distasteful materials, tape it up, and throw things out in a way that makes sense so that pets, kids, others won't have access to that. And of course, we also work on and help oversee the community drug take-back programs. And April 30th, as the commissioner said, is the next one. And finally, we are involved in, we helped pass the law last year and create the program with a lot of input on pharmacists prescribing naloxone. I'm happy to say that the training program is up and running. We now have over 400 pharmacists certified to prescribe. The numbers have been increasing rapidly because we have CVS, Rite Aid, and Walgreens now committed, so you get large chunks of pharmacists with those organizations. And it's a crucial thing, this program, because while a key goal, of course, is to make sure that naloxone is out there, not just by doctors prescribing or by first responders that we have here having the naloxone in emergency situations, but to make sure that family members, friends, neighbors who know of people, loved ones, or whatever that are at risk have the naloxone available. But the goal actually is never to have the naloxone be used. So what our training program attempts to do is to give, one, best practices in the case of an overdose or danger, because it's not just about the naloxone. There are other best practices in those situations. But also to, in a holistic way, connect the pharmacist who's on the front line, who has somebody coming in seeking help. Statistically, that is a very good time to be able to get that person in front of you to get their loved one, their family member, their neighbor into treatment. And so this is trying to foster connections between the pharmacists, the pharmacies, and local prevention and recovery organizations. Get them information so that you get somebody into recovery, and therefore the naloxone hopefully will never need to be used. Naloxone is great, it's important. My brother-in-law was alone. Naloxone didn't do him any good. So it's really, we want to kind of get a solution on the ground that will get the naloxone out, but that will also help prevent death and serious injury going forward. And one last thing, as I hit 8 minutes, I'm dropping the ball here, is we also oversee the medical marijuana program. I just raised that because it is a viable alternative to opioids. Now, it is still a Schedule II drug in Connecticut. It is still highly regulated. It is not free of danger, without a doubt, but it is an alternative for certain things that opioids are used to treat now, and it does not have the same level of risk and danger of both death from overdose, of course, that doesn't happen, and even on the addiction side, it's a little bit different. So I just wanted to throw that out as food for thought, too.
Thank you, Commissioner Harris, and I'm sure I join everyone here in our condolences on the loss of your brother-in-law, and I'm impressed by the fact that you took that loss as kind of an impetus to help bring about change. So thank you. And next we have the Chief of Police of the City of Waterbury, Vernon Riddick.
Good evening. First, I just want to acknowledge Sergeant Gary Angon. He's second in charge of our Vice and Narcotics Division, and he's also a supervisor for our Violent Crime Unit. He's a specialist, one of the specialists that we have in this area, so when we get to the Q&A later, please feel free to utilize him for a resource. Just for a point of reference, we had in 2013 roughly 116 heroin-related arrests. In calendar year 2015, that number increased to 1,170 arrests. And you have to understand that part of the arrest is not just a simple possession of the drugs, it's also the larcenies, the burglaries, which are associated to this, because people who have this addiction will do pretty much anything to feed that habit. So it's very important to law enforcement. I heard someone talking earlier, the commissioner, regarding medication drop boxes. We have one of those in the police departments. In our front lobby, just turn right to the right, and you can drop off your medications there. Over-the-counter drugs, prescription drugs, medication samples, and the like. In 2015, we had 47 pounds of pills. Now think about how light a pill is, ladies and gentlemen. 47 pounds that we recovered last year. Going forward, our seizure totals, and a lot of this was done by Vice and Narcotics. The Vice Squad in 2015, 14,658 bags of heroin. That's what's available out there. We also work very closely with NYPD, New York Police Department, and as well as statewide narcotics and federal authorities. It has to be a collaborative effort to try to stem this epidemic. Some of the concerns that we have is a lot of the drugs that were coming from New York were prepackaged. So it was set and it was for sale already. What the Vice Narcotics lately have been seeing is a lot of raw heroin, and what some of our local dealers are now trying to cut it with whatever. Fentanyl is one of the things, but who knows what they're cutting this heroin with. So it also can increase the likelihood of death, which is a serious problem for us. Also understand, we had an influx for a couple years of pills and pill cells. One pill on the street of Percocet goes between, $25 and $30 for one pill on the street. You can get a bundle of heroin. A bundle consists of 10 bags for roughly $40 to $60. In the Gold Coast, the Fairfield County, that same bundle goes for $100. And around Danbury is around the same, but in Waterbury it's $40 to $60. So that's why we have an issue here that's cheaper. Preventative measures that we're trying to do and changing some of our focus. All of our patrol officers carry Narcan, whether it's on their person or it's readily available in their vehicle. Anytime we respond to a heroin overdose, we consider it a crime scene, and we treat it as such. In addition to our detectives be responding to the scene, we also have our forensic units which responds to the scene, collects evidence, and takes pictures. We've assigned a detective assigned to our Vice and Narcotics Division that is primarily his sole responsibility now within the last couple of months is to track any heroin sales, heroin deaths, or heroin-related incidents, opiate-related incidents, which we've never had to do before. And another thing, we're really changing our focus from the law enforcement to more of a holistic approach, believe it or not. Understand that the impact this has on families and everyone. And again, Sergeant Angon, Detective Hayes, and Detective James Dickey, their idea was to pull in some of these families and have the families talk with each other afterwards. For law enforcement, that's a big shift. That's normally what we do. Are we experts in this? No, we're not. But has it made a difference? Yes. Just the mere fact that people who have lost loved ones, a shared loss, can just sit down and talk with each other, and in our presence is just very therapeutic for them and for us. And the unintended consequence of this is we're able to get some intel or intelligence on where they're buying the drugs, purchasing the drugs, and who some of their suppliers are. So that helps us. The street level people are one thing, but it helps us to make interventions at the mid-level and the higher level dealers that we have to deal with. And lastly, this is a great idea, Mayor. It really is, getting a bunch of different people at the table, and the hopes is we can exchange our information afterwards and we can provide help and assistance to each other to stem this terrible, terrible epidemic that's ravaging all of us. Thank you.
Thank you, Chief Riddick. I'm impressed by the innovation of every single speaker so far of the things that are being developed here. And what was the name of your, let me get your name again in case people want to address questions to you. Sergeant. And that last name again? Sergeant Gary or Harry?
Gary.
Gary. Okay, Sergeant Gary. That's going to work for us. All right, thank you very much. Next, we have Dr. Peter Jacoby of St. Mary's Hospital Emergency Department. Dr. Jacoby.
Well, where to begin? I could probably sit here and tell stories all night long about what we see in the emergency department.
Okay, I've set the timer.
But I will not. I'm going to break my brief remarks up into 3 different areas. One was the whole CDC guidelines that came out last month. One where they talked about, the greater than almost 30,000 deaths in 2014 from opioid prescription items and from heroin. And when you think about that number and put it into perspective of motor vehicle crashes, plane crashes, anything else, it's an absolutely frightening number. Therefore, the CDC came out and put out their recommendations, which we as a physician group wholeheartedly endorse. I absolutely love it in the emergency department because when someone says, I really need Percocets, I go, yeah, and the feds won't let me do it. I'm real sorry. But that has its downside. Because I worked clinically today, and when I told the patient he wasn't going to get the oxycodones that he requested, and I had gone on to CTPMP and seen what he had already received, about 5 minutes later he became quite irate, took his walker, smashed the computer, smashed at the desk, and screamed obscenities at everyone around there. And thanks to the Waterbury PD, he was then escorted out of the department in a nice, orderly manner. But we're up against this every single day. There is no one who doesn't present, or no doctor who works in the emergency department, Dr. Goweg from Waterbury could say the same thing, who isn't asked at least 4 or 5 times a day, can I get my prescription? Can I get Percocets? Can I get oxycodones? So we know it is truly a disaster out there. Now, there are a couple things I'd like to mention. Narcan only saves your life. It is not the end all. It is a great medication. Mayor, we were here last April, I believe, holding a forum talking about how we wanted to allow Narcan to be used by all first responders, which has saved, I can't even imagine the number of lives just in our small area. But I need you to hear something, that in the first 2 weeks of the Waterbury Fire Department using Narcan, of their 15 saves, 11 were from outside the city of Waterbury, which means people are coming in and to buy narcotics. And the mayor and I were talking last week, and I do have a fear that we will see more heroin. As the opioids get less and less, the prescription items are less on the street, we're going to see more heroin. It is cheaper, it will become almost easier to get, and will make their life even tougher to try and keep it under control. So we're up against it. A couple of other things I'd like to mention, because there are many physicians, as the chief mentioned, with the sergeant right here in front of us. There are physicians in this audience. Mark Krause, who is a longtime colleague, Chief Medical Officer of Connecticut Counseling, Vice President of the Association of Addiction Medicine, myself, who have been instrumental working in the American College of Emergency Physicians, both nationally and locally, and all of us together are available to help. We at St. Mary's hand this pamphlet out, and it's not about St. Mary's, it's about what's available in the city and surrounding areas of Waterbury. And we list on it the Suboxone Clinic, for example, that Gary Steck runs out of Wellmore. the Waterbury Hospital Clinic, Rushford and Cheshire. So we mention as many places as possible. This is not about any one institution. It is about what we together can do to fight this deadly scourge, as the chief said. So I will leave you with a couple of thoughts. We're behind it 100%. Narcan is only a lifesaver. Your life was saved today because death would have eliminated recovery. But you're going to go back out there tomorrow, and if you don't get into recovery, eventually death will win. So I'll tell you a very funny story that was just 1 week ago, or not, was it? Yeah, last Monday. Chief Martin called and said, would you want to go down to the fire station with us? Senator Chris Murphy's coming in, wants to talk about the use of Narcan. And I was working clinically, and I said, Chief, I can't get off the floor. It's just too busy. I walked out of the room. I was talking to him. The next patient I see was sent in after the fire department had responded to an overdose and used intranasal Narcan. And I looked at the kid and said, I feel like picking you up, calling for a police escort, and bringing you down to the fire station right now for a photo op. But this is what we're up against every single day. And I can't think of a day that goes by that I work clinically that I don't see an overdose come in. And the ambulance services can attest to it. The police can attest to it. The fire department can attest to it. So it is a scourge nationally and within the city. And I thank the mayor and everyone else for putting this together. It's a start. It's from here we move on and see what we can do. The medical community is behind you 100%. Thank you.
Thank you. Thank you. I'm going to defer right over to the next speaker and continue to listen, and then have some comments maybe at the end of the evening.
Just to follow up with what Dr. Jacoby was talking about, ask any one of our patients, what do they do to find the best heroin? And they'll tell you they talked to somebody who just overdosed. Seriously, where'd you get that stuff? That's what I want. That's what this disease does to one's judgment, to one's thinking. And we are really up against it. I'm going to start by talking a little bit about Connecticut Counseling Centers. I don't want to take very much time with that. I'm just going to give you a brief overview. Then I want to talk a little bit about a couple things that I noticed from the treatment provider's perspective, things I think that we as a community can focus on. Connecticut Counseling Centers is an outpatient treatment center. We provide mental health and substance abuse treatment. We're in Danbury and Norwalk, in addition to Waterbury, and one of our largest populations that we treat are folks who come in addicted to opioids, whether they're prescription narcotics or heroin. And we use a variety of services to aid them in their recovery, including intensive counseling services, medications if that's needed. One of the things that we find with the average person coming in, whether they're from an affluent family or from a very humble upbringing, is that they come into treatment with a variety of issues. It's never just the addiction. There's always other things that need to be addressed if their recovery is going to be sustained and is going to be long-term. About 70%, actually it runs somewhere between 68 and 75%, depending on which statistic you're looking at, of folks coming into treatment for substance abuse problems such as opioid addiction also has a concurrent mental health issue. Whether that to be a mood disorder, anxiety disorder. One of the most common disorders we see is trauma. There's a tremendous amount of trauma we see in the folks that come into treatment. Either trauma that they experienced before they decided to turn to opiates, or trauma that they experienced during their addiction. And these issues need to be addressed as well. One of the things that we do and a lot of providers now focus on is making sure that we not only address the addiction, but also the mental health issues and also the physical issues. Because as Dr. Kraus can attest to, and I'm sure Dr. Jacoby can as well, the average person addicted to narcotics also has a host of other medical problems that need to be addressed. So one of the things I wanted to say today is that treatment really needs to be comprehensive. It really needs to address all the needs of the person. If their recovery is going to be sustained and going to be long-term, it's not just addressing the addiction. Address the mental health issues if they're there, family issues, physical issues. That's why it's really important that the entire community be on the same page. Historically, believe it or not, you look back a few years, the mental health community, the substance abuse community, and the general medical field traditionally never really worked that closely together. And it's amazing, but true. Recently, that's starting to change, and that's good. I think that we do a better job working together. But as a community, I think it's important to realize that folks who are struggling with addiction usually have a lot more problems than just the addiction itself. One of the things, if we're going to adequately address this, we have to make sure as a community is in place, is that treatment is available on demand. And I'm sure the Demas Commissioner would agree with this one. I think about the window of opportunity to provide treatment is kind of like one of those sliding doors, automatic sliding doors. You stand in front of it, it opens, but you step away and it closes pretty quickly. For most folks, when they stand in front of that door and they ask for treatment, they're usually there for a very short period of time. And if treatment isn't available, if it's not ready when they're ready, they'll walk away. And we see that in the research. Every treatment provider who's here, I'm sure, would echo that. So we have to make sure that treatment is available on demand. Well, one of the things that I worry about is that treatment will be there. I think that it's important to increase community awareness. I think that comes first. Get the message out there. But when people come in and they're ready for treatment, the treatment community has to be ready and prepared to provide that treatment. So to me, that's an important piece of it. I'm sure Dr. Jacoby would echo this sentiment. We see far too many people going into the emergency room or going into detox and then not connecting to long-term care afterwards. Recovery from narcotic addiction is a long-term process. It's a lifelong process. And far too often what we see when folks are just going in for very short-term care is that they end up relapsing fairly quickly. And believe it or not, it's at that point that they're most vulnerable for overdose because their tolerance has been decreased. And one of the things that far too often we see is the person going in for a detox, going into short-term treatment, getting off the opiates, decreasing their tolerance, relapsing, and going back to use what they were using when they detoxed. And of course, now their body can't handle that. So treatment needs to be long-term. We're not talking about a 1-week fix or a 30-day fix here. This is a long-term process. It's important that we have that connection to care, from the emergency room into treatment, from residential to long-term care. We talked about, I mentioned briefly, awareness, community awareness. One of the biggest barriers I think that we as a treatment community as well as a general community faces in addressing this problem is stigma. People don't want to talk about it, right? Addiction is still viewed by a large segment of our population as a moral failing instead of the medical disease it is. People are ashamed and they don't want to come forward and talk about it. If we're really going to address this epidemic, we have to stop being afraid to talk about it. And we got to come together as a community the way we would address cancer or any other physical disease. And unless we can achieve that, I'm afraid we're going to fall short. So that's why I think these kinds of forums are so important to get the dialogue started. Start talking about it. This is a medical disease that as a community we need to address. The other thing I'm going to mention real quick that I think is on the horizon, and it's really, really going to be important to addressing this epidemic, is providing effective treatment services while the patient is incarcerated. The Demas Commissioner mentioned some initiatives that are underway. I know of two in Bridgeport and New Haven where methadone, which is a very effective medication, as along with buprenorphine, methadone is given to patients while they're in jail, and before they're released from incarceration, they're connected to a clinic. Research that has been done on these kinds of initiatives in other states have shown it to be extremely effective, and I'm really hoping that as a state, we can expand that statewide and provide that in every community, because I think that's, when the person's arrested and incarcerated, I think that's one of those points where the window opens for a brief period of time, and I think we need to take advantage of that. So I don't want to talk too much, so I'll cut it off there and turn it over to the next panel.
Thank you, Mr. Lambert. And so when we come to questions later, folks that have questions about methadone maintenance, some of you may or may not know what that is. Now you know where you can direct those questions. And then you mentioned stigma, and I think we're really fortunate and blessed here tonight to have Lee Early, who is willing to break the silence and address the stigma by sharing her own story. Lee Early.
What the gentleman to my right just talked about spoke very much to my heart. I was a professional. I broke my arm in a car accident. I started taking pain meds through multiple surgeries, and the surgeries took a couple of years to finally get them all straightened out. So by this time, I'm on pain meds for a long time. Probably overprescribed, but that's neither here nor there. But the ease at which I then went from a professional, an assistant director at a university, a mother, a daughter, everybody knows the horror stories. The ease that I went from that to a heroin addict on the streets of Waterbury, because I'm from a suburb and it's very, very, very simple to get, and probably even easier now, is just baffling to me. And throughout all the talking, I keep thinking, yes, it was a physical problem, and yes, I became an addict because of that, but that's not really the only why, and if I could answer that, God bless me. But as we were discussing, I think it's really critical to get to the why. Why do we now want to legalize recreational marijuana? Why do we want to change how we feel? Why was getting rid of the pain for the small amount of time I needed it not enough? There's something more behind it I think for almost everybody that really truly becomes addicted, more than just that addiction piece. As you were saying, the mental health piece, the physical ailments and whatnot. But, and if I didn't get incarcerated, I'd probably be dead. So that window did open right then and there, and forced into long-term residential treatment. And I'm in treatment to this day, 9 years later. So it's not, there is no easy fix. There are no easy answers, but it is very, very doable. So that's my story.
Lee, can I ask, so you spoke a little bit about kind of what got you there. Can you mention, what were the kinds of things that helped you in your recovery?
Imprisonment. Sorry,
Okay,
but it's
fair.
the truth. I truly, as I just said, think I probably would be dead. Was family intervened, had me arrested. I actually went on that bus to Niantic. I'm just this little girl from Woket, Connecticut. It was the wake-up call of my life. My daughter was gone. My home was gone. I didn't have many alternatives at that point. And being away from home into forced 6-month inpatient rehab gave me the time that I needed to take a look at myself, and first of all, to get the stuff out of my system. You know, I had been to pretty places up in the Western Hills and done my 30 days and AA and NA, and it's wonderful, but for me, at that stage in my life and in my addiction, it just was not, there was no way that was gonna cut it. I mean, this takes over. I don't think I'm a horrible human being, and I would have sold my mother's soul at that point. So it took long-term, inpatient treatment and many, many years. Like I said, I'm still, you know, I still go to therapy. I use medication therapy when I needed to. I don't know why, but my body, after years of being on opiates, I could not feel like I had the flu when I stopped using. I mean, every day, all I did was ache. You know, I had to use medication replacement for a long period of time just to be able to function. So what helped me was people persisting but not enabling, and finally committing and being committed, at first not on my own account. I didn't want to do this. It's the length of time. The length of time you can stay away from it turns into another day. It sounds kind of silly, but that's really all it comes down to. If you can get somebody away from it for just a big enough window to clear it up and look at the other stuff that might be going on, whatever it is, medical, mental health, then you have a shot, you know, but all things have to kind of come together at once.
Thank you, Lee. I'm glad they came together for you. All right.
Could I just jump in and say something there? Because she brings up a really important point. We need to realize, and I'm sure that the physicians in the room could say this more eloquently than myself, but we have to realize that people who are addicted to opioids have profoundly dysfunctional brain chemistry. That over the course of using these opioids externally, their brain has rewired. And it's not the same anymore. And it doesn't go back to normal right away. And during the recovery process, oftentimes what we see is the person in recovery struggling to maintain sobriety with this dysfunction or this disordered brain function, and oftentimes without the assistance of good intensive counseling and medications, oftentimes they end up giving in. So we have to realize that after somebody's been addicted for a long period of time, their brain is changed in long-term and profound ways. And it's not just a matter of they need more willpower or they need a little bit more character to pull it together. We're talking about a physical disease process, and we need to recognize that and treat the medical aspect of it if we want to give them a real chance of long-term recovery.
Thank you. Well said. And I think it's becoming clear that this is not a one-size-fits-all problem. And to address the next part of it, which is the prevention component, Jennifer DeWitt, the director of the CNV-RAC.
Thank you. Janine, you know you have to time me, right? Good, because I can talk. So I just want to start by thanking all the other panelists so far. And Lee, you really ended by starting what I wanted to talk about, which is that in addition to being the RAC director, I'm also a licensed addictions counselor. And if I could simplify addiction as much as humanly possible, I would call it a feeling management disease. Because in my experience in working with teenagers and adolescents and in schools and at the earliest level of risk-taking behavior, it's a feeling management problem. It's, I want to feel better, I don't want to feel anything at all, I can't deal with the anxiety, I can't deal with the boredom, I can't deal with the depression. It's self-medicating in so many different ways. So we asked why, why do we use substances? Why do we try our first drink of alcohol or our first, toke of marijuana or something else? It's because we're trying to feel better, feel good, not feel at all. It has to do with our feelings. And so when I think about prevention, when I think about primary prevention, I think about teaching our children coping strategies, how to cope with disappointment, how to cope with upset feelings, how to identify and communicate their feelings, which is really hard work in the age that we live in. So when I think about primary prevention, I know we're talking about opioids tonight, but I really think about talking about alcohol, electronic cigarettes, marijuana, and other substances. Because 3 out of 4 heroin addicts started with prescription drugs. And the prescription drugs that they started with weren't their first substance that they used. So when I think about primary prevention, we have to have those conversations early, have them often, and have them over and over again in developmentally appropriate ways with our children. And the first people that have those conversations have to be their parents and their primary caregivers, as scary and uncomfortable as it is. The next person that has to have that conversation is the people that they look up to in their schools. And so when we talk about prevention and education, what needs to happen is schools need to be using an evidence-based substance abuse prevention curriculum that's kept to fidelity in the administration in the school. So it can't be, we have 22 sessions of life skills training, but we can only deliver 10, because that's not keeping it to fidelity. And there aren't enough schools that are able to, or that are using an evidence-based substance abuse prevention curriculum as part of their health curriculum. Another important prevention strategy is those same schools where our children are being educated are great places to educate our parents. So having a series, a parent education series about everything from sex, drugs, and rock and roll to bullying is, again, a great way to infuse that education in the primary prevention arena. Family dinners are important. The more bonded to our primary caregivers we are, the less at risk we are. Also, having a welcoming, friendly school climate, the more bonded to school children are, the more interested they are in success and the less at risk they are. So there's a lot of different things that we can do. My colleagues have talked about stigma. They've talked about medication drop boxes, which we've got 5 in our 12-town service area, so you should know about them. Just about every other town has one: Waterbury, Watertown, Wolcott, Naugatuck, and I'm missing one, Cheshire. So we have medication drop boxes, and those conversations should happen at home too. Parents, are you safeguarding your medications? And adults, have you had a conversation about this kind of pill for every ill environment that we live in? Because part of prevention is environmental prevention, changing the environment where substances are used. And the environment right now has a low perception of harm of alcohol and marijuana, and it has a very permissive culture of let's go to the doctor for every little pain instead of, rest, ice, compression, elevation, fluids, sleep, things like that don't require things like Tylenol with codeine and medications for every boo-boo we get. And so those are parts of the conversations that have to happen also. The legislative piece, I don't think, can be stated enough. There are things happening in our state and there are things happening federally. You have to pick up the phone and call your legislator and tell them the things that you're concerned about, because they do care and they will listen. Kids. We have an atmosphere in our schools where it's no longer cool to be a member of Students Against Destructive Decisions. Nobody wants to be part of their SAD chapter because being substance-free is not cool. That has to shift. Many of you have heard about or maybe even seen Chris Herron's presentation. He's been all over the state and everywhere, and he talks about this program called Project Purple, where kids wear purple, like me and Janine, in recognition of the fact that it's okay to be sober. In fact, it's kind of cool to not need mind-altering substances to have a good time and to have some pride in that. That's a culture shift, that's an environment shift, that's a challenging shift, but that's another piece of the prevention puzzle. Law enforcement keep doing what they're doing, and they need our support as well. And I love the piece that you said about, for you it required incarceration. There are so many families that I work with that have such a hard time setting that firm boundary or closing that door or not bailing their kid out. And sometimes our kids need to fall hard before they fall so hard that we can't pick them up anymore. And that is the hardest thing for a parent to do, but there are professionals out there that can support you to do that and to set those good boundaries. Physicians, I know we've had multiple talk about all the different great things that are going on. I'm so glad you talked about the CDC guidelines. And screening, brief intervention, and referral for treatment is a tool that we know is not used enough. Pediatricians tend to grossly underestimate the amount of substance use happening with their patients. And so getting trained in that early screening model and knowing how to have those conversations and refer those adolescents for appropriate treatment supports, and then having those appropriate treatment supports are another piece. These are all pieces, many, many pieces of the pie. So I think I just want to close by saying Mayor O'Leary is going to talk with you about some things starting here in this community and that I hope trickle to our outer communities as almost a regional event if we can. We have to have the conversation. I hope that after this evening, you will think about the things that were talked about here, come up with your creative solutions, because there's a lot of really creative ways out there to address this multi-pronged issue, and come back to the table with us. A few folks have said this is the starting point, and it really is. This forum is the beginning, it's not the end. In your agenda, there is a piece of information at the bottom about a follow-up meeting that's going to happen at AMR here in Waterbury on April 21st for individuals who are interested. We want to hear your solutions. I'm going to brainstorm the heck out of your solutions. I'm going to take them all down. We're going to come back to the mayor's office and we're going to talk about it. And I think there are some great things that are going to happen as a result. So please, mark that in your bonnet and on your schedule and on your iPhone as the next step, because there are many next steps to be had. Thank you so much.
Mayor O'Leary.
Well, I'd still like to hear more, so I thought maybe it'd be a good time to hear from some of the folks that are here with us this evening.
All right, thank you. So two things. First of all, Jim, give a little wave, is here. Everybody had an opportunity to get a card when they came in. If you want one and didn't get one, there are still some out on the table. If there's a question you would like to ask, but you're not comfortable asking it, very publicly, just write it down and just kind of wave it, and Jim will come around and collect those. If you'd like your question directed to a particular panelist, you can put that at the top, or I'll just collect them and then we'll see who wants to give it a go. Alrighty? So there's Bill with more blank cards. So if anybody needs those, and anybody have any questions they would like to hand in? Alrighty. While you have a moment to do that, I'm going to add my little 2 cents to Jennifer's thing, and I have to say, working with the RAC directors in the state has been so illuminating to me. And one of the points is around when she talked about the medications, and Lee, you spoke about how you got your start with that. So my kind of way of capturing it is, I know so many people who have gotten their bottle of OxyContin for dental work was one. This was my favorite when I heard somebody got 30 pills for one tooth removal. That was kind of the top. Or people get them for their hip replacements, shoulder surgery. They put them in their medicine cabinets and then forget about them. So having heard, and who was it? I think it was Chief Riddick. Didn't you give me the number? That one Percocet's $25 to $30. Was that you? Yeah.
That is correct.
Okay, so how many of you, knowing how vulnerable kids are, would leave a wad of $20 bills rolled up with just a little flimsy rubber band and leave that sitting permanently in your medicine cabinet for your kids to see day in, day out, for their friends to see, and never take one bill if they thought you didn't even know how many were there? So if you wouldn't leave a roll, oops, okay, that was, no, you didn't use up all your time. See, you had all that extra time, Jennifer. So if you wouldn't leave that bottle of opiate pain medication in your, if you wouldn't leave the roll of $20 bills there, I'm going to argue that you shouldn't leave the bottle of opiate medication there. And you said in the lobby to the right?
Yes.
Dropbox in Naugatuck, in
Woolkit, Watertown, Cheshire.
You can get there from here. So with that, all right, you've got a question? Sure, you want to go, and I'll ask people to go up to the microphone.
Just be careful of the cord.
Maybe we should move, can we move that up so people, is that all right?
Yeah, absolutely.
Hi, your name, please.
Hi, my name is Dr. Sandra Valenti, and I'm both an educator, Naugatuck Valley Community College. I run the drug and alcohol counseling program where I'm training students and educating them to be addiction counselors. But I'm also a private practitioner, and I've been working with mental health co-occurring clients for over 15, 20 years. And I concur with everything that has been said. We ran a smaller forum at the college about a month ago, but one of the things that has continually come up for my clients has been access to treatment, trying to find access. There's a shortage of psychiatrists, and I know Dr. Jacoby, we're well aware of that issue, the need to get more psychiatrists to address co-occurring disorders. Access to treatment also, as Lee had talked about, the fact that we need longer time in treatment. We know from research that the longer a client can stay in treatment, either using recovery coaches through individual therapy, whatever treatment we can provide those individuals, we need to do more to keep them in treatment so that they don't go back on the street. Now, one of the things that has been challenging to us is insurance companies. They seem to be a primary block in some cases to preventing individuals to maintain access to treatment. And so one of the things that I have always advocated for and that I've talked a lot about wanting to work with is the insurance companies. How can we get them to the table here and talk to them? We need people like Lee, like myself. I am also an addict in recovery, 25 years. And just to say, you know, I threw that out because look where I am. It wouldn't have happened if I didn't get into treatment. But the point is, we need to talk to insurance companies. We need to do more with them to encourage them to allow our clients to stay in treatment. We're kicking them out before they're ready. Recovery coaching, I want to throw that out, not just as a treatment provider, but we have recovery coaches who will also help support that. Another thing, and I'll sit down, has to do with education. It was mentioned here at the table about educating children in the schools. Mayor O'Leary, we have a program of students who are willing to work in Waterbury Public Schools, but we have to start early. We have programs for children. We have evidence-based programs, as Jennifer has talked about, but these programs have to start early. We need to start at kindergarten. I've proposed, in fact, not myself, it was one of my dark students when she designed a prevention program, proposed a program that started at the kindergarten level. Rather than having gym every day or every week, why can't we do a substance abuse education in place of one gym class at every grade from early ages on? If they hear it repeatedly, they're more likely to hear what we're saying, to incorporate it into their beliefs, and incorporating parent education as a component of that. Thank you.
Thank you. And I believe Commissioner Delphin Rittman would like to make a comment.
Yeah, I just wanted to thank you for your comment and to acknowledge that we have folks here from the Department of Insurance and also from the Office of the Healthcare Advocate. And these are two state departments and units that really can help around advocacy and many of the things that you talked about. And so I just want to pass the mic briefly, if that's okay, for them to talk a little bit about what they do.
Good afternoon. My name is Gerard O'Sullivan. I'm the Director of Consumer Affairs with the State of Connecticut Insurance Department. And I did bring a couple of our pamphlets for folks. And this one we just created a couple of years ago, Consumer Toolkit for Navigating Behavioral Health and Substance Abuse Care Through Your Health Insurance Plan. And Jennifer had talked before about changes the legislature has done. And just in the past 2 years, there's been significant changes to requirements on insurance companies. Specific requirements of the guidelines that they have to use in approving or denying care. And one of the other things that most folks don't know is it's not up to the insurance company ultimately. Ultimately, it's up to an independent third party through what's called external appeal, which is done through the insurance department with the assistance of the Office of the Healthcare Advocate. And it's an independent doctor who makes the determination as to whether or not care is medically necessary. So if you're having problems with your insurance company, don't let that be an obstacle. Contact us, contact the Office of the Healthcare Advocate. We're there to help.
Thank you.
My name's Damian Fonsanella. I am the General Counsel with the Healthcare Advocate. I'll keep it brief because there's a lot of you that I'm sure want to make comments or ask questions. We are a free service. I always got to get that out there for anyone in the state that has questions about how to use their insurance. And that's kind of a fundamental piece, because one of the things that's come up a lot here is access. We can get people, we can save lives, but getting them where they can maintain their recovery is the critical part. And we see every day, we get people calling us and saying, my child's went through detox last week. They're impatient and they're going to get kicked out because the insurance won't pay for it anymore. What do I do? I had 2 weeks ago, mom called, young child, went to the hospital, wanted to go voluntarily into detox, but she didn't meet the criteria because she didn't have a positive urine. So she went home, OD'd, because she was trying to get a positive urine to go into detox. Not a good outcome for her. What we do as an agency, we work very well with the insurance department to gather information from all of you across the state so we can bring the information back to our commissioners and the legislature so we can make informed, effective policy changes like Gerard talked about, changing the criteria that are used to measure whether someone actually needs a service or not. There's a lot of money that goes into this, and we have to make sure that it's spent wisely, both on the commercial insurance side as well as on the state side. But it doesn't mean that we don't need to spend it. We need to make the investment in our future. And what we try to do, one person at a time, is help individuals get access to those services that they're entitled to by their insurance. But it's a complicated process. So if you or a loved one is having a problem accessing services, they're at risk for getting kicked out of a program, reach out to us, reach out to the insurance department, reach out to one of the many, many resources and advocates around the state and ask them for help before you, your loved one, your child is out on the street, so we can start acting expeditiously while they're still receiving the service they need and we don't interrupt that care. Thanks.
Is that a question related to that? Absolutely. If you would grab a microphone and give again your name and a phone number, because I think you may get a lot of calls.
Well, we do have a 1-800 number too. Actually, I have brochures on the table, but we are the Office of the Healthcare Advocate. It's ct.gov/OHA.
And a phone number?
866-466-4446.
4446. And your name again, they're going to ask for you.
Damian Fontanella.
Damian Fontanella. All
Yes.
right. You got that name?
And I'll be around if you have questions.
Thank you. And that's helpful. So afterwards, if somebody has a particular question, Damian will be able to answer them? All right. And Dr. Kraus, you had a question.
Thank you very much. I first of all, I'd like to thank the panel, I think, and all of you being here. I've been in addiction for 40 years, and I was the director of addiction at both hospitals. I am now the Chief Medical Officer of Connecticut Counseling. I have many different titles, and one of them is the Vice President of the American Society of Addiction Medicine, which was very much part of the CDC guideline. The Chief, you talked about the death rates, they're out of sight. You talked about it being a disease, which is what it is. It's a chronic brain disorder. And if we had a epidemic like diabetes, hypertension, or cancer with the statistics that we have, just think about it. People would be screaming, help. We've got to break the stigma, because without that, we're not going to get anywhere. And I've been involved in lots of different groups that have started things. I was on the Blue Ribbon Task Force, which started the ADCP. I was involved with the governor, Rowland back then, and different governors. And the problem is that we can't just let it stay here. And if you walk out of here and it doesn't really resonate that we have to do something, not just one group, the politicians or the doctors in the emergency room or the police, we've lost. We've lost. And I've taken care of kids because besides being out there in the political part and in the administrative part, I'm also out there as a practitioner in terms of an office. I am general internist in Waterbury. I do addiction medicine in Waterbury. And I've taken care of 12-year-old drug addicts who are shooting up heroin. Can you imagine this kid's life? He has none. In my mind, there's none. He's finished. It's done. And his parents are going to suffer the tragedy of a lost child. Because why? We didn't come together. So I applaud you for wanting to come together. I hope that we don't leave this. Remember that it's a disease like hypertension and diabetes. There's medical-assisted treatment, evidence-based, we've proven, that for not just one drug, but for many of the drugs, and the research is going on. And we can make a difference because it's a disease that not only medicine, but psychiatry and psychological interventions really work. So I want to thank you. I hope this continues. I also want to say, as my hat as the Connecticut State Medical Society's director or chairman of the section of addiction medicine, and as a member of that, as well as the chairman, as well as spoke today with the Waterbury Medical Society, we're behind this 100%, and we'll do anything we can. Just remember that it's all education. It's not only educating the public, you guys and me included, but also educating physicians, educating teachers, the media. We have to do this together. And if we're not rowing at the same pace, the same way, we're finished. So I thank you very much for being here for everybody.
Thank you, Dr. All right, thank you. I know Jennifer's got a question that was submitted by someone in the audience.
Yes. The question is, can you please explain Project Purple? So Project Purple is an initiative that was developed as part of the Chris Herron Project. For anyone who doesn't know who Chris Herron is, he's a person in long-term recovery. He was an NBA basketball player who became addicted to heroin, and he speaks around the country to high school audiences, to middle school audiences, to parents, family caregivers, and the general public. And he talks about the start of addiction as opposed to where it ended for him. And so as part of his project and part of his campaign, he went to a school and there were a group of kids in the front row wearing purple t-shirts who were a little bit laughed at in his presentation. So he stopped the presentation and talked to the kids, and what he found out was that they and their purple t-shirts represented the 4 kids in that school who decided to be alcohol and drug free and were being laughed at for their choice, and how silly that is, because that's not normal for teenagers, wink wink. So Project Purple started as a result because he wanted to applaud those kids and encourage additional groups of youth who choose to be alcohol and drug free to continue to do so. And so Project Purple is a campaign that schools can utilize to provide peer education. So it's not adults talking to kids about it, it's kids who've decided to be alcohol and drug free educating their peers. So it's education and awareness raising, awareness about substance use, about other choices, about other ways to cope. And many of you have probably heard of like Prom Promise and Project Graduation. They do those kinds of efforts as well as part of Project Purple. It's the program du jour, but it's the same as Students Against Destructive Decisions. It's the same as other, positive peer supports that are in schools in various forms. For any of your schools that have a peer helper program, that's a similar program to Project Purple, where there's peer education for kids who are concerned about whatever it is going on with them, to be able to talk to other kids their own age about the things that they are struggling with and to get support. So that's what Project Purple is. You can Google it, you can find more information out about it, and it's just one of many different positive peer supports for teens who are interested in being alcohol and drug free.
Thank you. And I think we have another question from an audience member.
Tall people. Good evening. Paul Singley with the Republican American. I'm covering the event tonight, so normally I'd ask questions to the panelists, but I have a question that I wasn't sure who to address to, so I figured I'd ask all of you. First of all, I just wanted to say that this was an amazing event, and everybody really brought something to the table, so it was great. Chief Riddick talked about how many people steal money to get drugs, and Ms. Early talked about how incarceration actually helped her. So my question is, what happens at the court level to A, identify criminals who have addiction problems, especially those who are uncomfortable with coming forward, and then B, to get them the help that they need? I have a follow-up to that question, but...
We have a prosecutor here from the court, John Davenport. Maybe John could shed some light on your question.
The general approach is there are a couple of programs that people who are using drugs get an opportunity to use. You actually have about 3 or 4 opportunities to get into a counseling and community service program before anybody ends up with a being criminalized by ending up with a criminal conviction. The focus is more to address seriously people who are selling the narcotics. There's a protocol that's just been distributed today. Chief knows about it. It went out to all of the area police departments about treating the overdose scene as a crime scene, not as to prosecute or to criminalize the person who's taken the drugs, but to use it as an opportunity to get information, evidence towards who's selling the drugs and where the drugs are coming from so that the police can direct their efforts there. You have the Good Samaritan law that protects people who call the police or call an ambulance to get help for somebody. So those are the kind of steps that are being taken on the prosecution end of the deal. Okay?
Related, but a little different. I hear a lot from people I know who are in recovery and also through covering this for several years now about the difference between outpatient and inpatient services. And I know we talked about identifying who needs what services. So I've heard a lot about how outpatient treatment really is less helpful. And I'm wondering if you could speak to that. Is it less helpful? Does it depend on the circumstances? And how do you identify who needs outpatient versus inpatient treatment? So thank you.
I could say
who's
a
gonna get
little
that
bit about that and then toss it off to whoever else wants to jump in. But it's important to keep in mind that we do have a wide variety of different services, including inpatient and outpatient. And the first thing I'd want to say is that there's no one type of treatment that fits everybody. And that's why we have a full toolkit, because we really need a lot of different approaches. It really depends on the individual. What they're willing to do, because that's an important piece of it, and what is necessary to address their particular addiction. Some people can find that they go into residential, and if they have the right supports when they come out, that they do just fine. Other people struggle at the end of a fairly short residential treatment. Some people seem to suffer with that, the brain disease piece of it. In other words, that disordered brain function sticks with them for a very long time. The research indicates it can stick around 2+ years after they stop using drugs. For those folks, they may need medications along with counseling and therapy in order to maintain their sobriety. I can tell you for opioid dependency, especially long-term opioid dependency, medication-assisted treatment, if you're just looking at the research, tends to be the most successful long-term. And I think a piece of that is because it addresses the chemical imbalance in the brain. But it's important to keep in mind that no one approach is important for everybody. There are specific criteria that providers and physicians use. ASAM published criteria that we all use, where we look at several dimensions of the person's life, how long they've been using, do they have co-occurring mental illness, do they have a drug-free recovery support system at home or not, do they have a safe environment. All these things come into play. But oftentimes, it comes down to the treatment system being agile enough to adjust to what the person needs in the moment, not taking anything off the table. But to say that one is more effective than another, I think it's a little bit misleading. I think we have to keep all of our options on the table. But again, for a lot of folks, long-term outpatient care, even if they start with the residential care, seems to be what's going to work in the long run. And I think that that piece of it also brings up another issue. But a lot of people, we talked about stigma in general as it relates to addiction. There's certain types of treatment that tend to be more stigmatized in the addiction treatment field, and that includes ones that include medication. The thinking that, well, if they're taking a drug, you shouldn't give them some other kind of pill that they're taking. But again, there's, whether they have a co-occurring mental illness or whether they are struggling with a long-term persistent brain disease piece of it, oftentimes addiction or medications will be an important part of that. We have to keep an open mind and say, hey, whatever's going to work for the individual.
And I think Commissioner Delphin-Rittman has an additional comment.
Yeah, and so I'd like to just piggyback off the previous point. So absolutely, the research often shows that medication-assisted treatment, along with counseling, is really what makes a difference in terms of long-term recovery. So to your question, in terms of what's more effective, inpatient or outpatient, outpatient services are effective if it's medication-assisted treatment along with counseling and other recovery supports. And in terms of the DEMA system of care, our strategy over the years has really been to develop and have a range of services and supports that are available, because we know there's no one, everyone's recovery journey is different. You hear all types of stories around sort of what the turning point was for different people or what levels of care were most effective. And so as a system of care, our aim is to offer a range of different services and supports. So detox, residential, 30, 60, 90 days, even 120-day programs, as well as outpatient. And then the other piece is recovery supports. We have a range of recovery support services as well. So housing, employment services, services to link individuals with other people in recovery who've been on a similar journey and who can talk with them about their own journey. And often people talk about that gives them tremendous feelings of hope. They see another person's walk and they realize, if that person got there, then there's hope for me in my journey. And so the recovery services and supports are really valuable as well.
Thank you, Commissioner.
And if I could just echo that just for a second, that really is an important piece of it, because we have to realize that, whatever the treatment is that the person's accessing, they're only engaged in that treatment for a short period of time, or if it's an ongoing treatment, for a certain amount of time each week or each month. Then they have to go out there and live their recovery. And it's very, very important that there is a recovery social network out there that supports them. So whatever the solution is, a lot of people mentioned here tonight recovery supports. That's a real important piece of it.
Thank you. And I think we have, now, how many of you are waiting for questions, and how of you just are, okay, so we've got a couple of people. If you'd please come up and ask your question or make your comment. Thank you.
Hi, my name is Susan, and my son is in recovery from heroin addiction, and he's been using Vivitrol and Suboxone. Vivitrol was by far the most effective for him. Suboxone is not accessible for a lot of people, and a lot of doctors are prescribing irresponsibly. Your department was wonderful. I know a doctor who's prescribing Xanax, Adderall, and Suboxone for my son. Healthy CT will not fill Suboxone and Xanax together. Anthem, Blue Cross, Medicaid will. It's a deadly combination. But I contacted your guys, and within 15 minutes I got an email back. So I was very pleased about that. The question I'd like to ask is, does the brain heal when they're using the medication assisted? And I've read a lot about neurofeedback. That seems to be something, because for kids who started using young, the brain is definitely damaged. And I think we look at them and say, why can't you control it? What's the matter with you? And right. I really believe that they're not capable. So I'd like to hear more about neurofeedback and other evidence-based practices that are working.
Sure, I can jump in and tell you what I know, and then I know Dr. Krause could jump in, and probably Dr. Jacoby as well. The brain doesn't fully develop until about 24 years of age. So yes, when somebody starts using as an adolescent, it absolutely affects brain development. How can it not? And the person is taking this external substance. When it comes to opiates, we have a natural occurring opiate system in our brains that regulates certain emotions and pain. When you take an external opiate, that neurofeedback then affects your endogenous opiate system, so that your brain is not handling pain and emotional response the same way, because it's been affected neurologically. So that feedback loop is certainly there. What's happening when somebody takes a medication like methadone or buprenorphine, we're not 100% sure. but I can tell you that the neuroscan research that has been done, especially with methadone, buprenorphine is a little bit newer, so it's not as much research, but it indicates that it normalizes brain function, and we don't know exactly the why behind that. But if you look at a brain scan of somebody on heroin, somebody maintained successfully on methadone, and somebody who's essentially drug-free, the two brains that look alike is the person on medication-assisted treatment, in this case methadone, and the person who's drug-free. The brain that looks very different in the scan is the one on heroin. It's technically an opioid, so it does bind to the same opioid receptor sites in the brain as abusable opioids, but it doesn't give the person the same rush or euphoria. What it does after it attaches that receptor site is a little bit different. So, you know, I guess the long and the short of it is we don't have all the answers in terms of what's going on. We do know that when the person lives a recovery lifestyle, and they're able to do that over a long period of time, that for many people, they're able to discontinue medication. Some people find that they can't. Other people find that they can. We do know there's something about that neurofeedback loop when somebody starts to live a drug-free lifestyle, that it does help rewire the brain. That's why talk therapy works. It's actually talk therapy is affecting the brain on a neurological level and helping rewire it. So there is something to that feedback loop that's happening during treatment and the recovery process. But to be honest with you, when it comes to the science of addiction, we're still in our infancy, or at least childhood, in terms of knowing what we need to know about it.
Okay, thank you. I want to make sure we have a few more questions. I want to make sure we have time to get to those.
Hi, I'm a person in long-term recovery. My name is Chris, and I'm also the public information chairperson for the Greater Waterbury area of Narcotics Anonymous. And I just wanted to speak a little bit about Narcotics Anonymous. We're a 12-step recovery program for people with the disease of addiction. We're a group of men and women who meet regularly to help each other stay clean. We do this by sharing our experience, strength, and hope. I want to talk about accessibility. There's over 300 meetings, nightly meetings in the state of Connecticut. There's a meeting every night in the Waterbury area, sometimes 2 meetings per day. Okay, some of the things that we do, we have a hotline number. If you call the hotline, a recovering addict will answer the phone and either talk to the person that's suffering, and we'll even arrange to take them to their first meeting, give them a ride to the meeting, introduce them to the program, introduce them to people in the meetings, okay? We're a peer support program, okay? One of the ways we do this is through sponsorship. A sponsor is a person we select to help us write the steps, okay? So the steps are exercises and spiritual principles that we write and we live in order to find out who we are, why we do the things we do, the issues we have, and we try to work through those issues. See, addicts have trouble living with or without drugs, and that's the problem, see? So that's one of the ways. The other peer support that we do is we believe that the therapeutic value of one addict helping another is without parallel. See, like the police officers get together to talk about crime, and the doctors get together to talk about the medical issues and whatnot. See, we're addicts. We're recovering addicts. You know, other people know how addicts act. We know how addicts feel, you know? And so we help addicts that way. And it's worked for thousands, hundreds, you know. Like I said, there's 300 meetings. There's over 80,000 nightly meetings worldwide in 130 countries. Addiction is a worldwide problem, and it has been for a long time. And it's really blossoming now. So, you know, there's other things we can do. CTNA.org is a website. You can have all the up-to-date meeting schedule. NA.org is the world website. Plenty of information about addiction and recovery. You know, not much about addiction, but a lot about recovery. I have literature out there. Please feel free to take it. The most important one is the meeting schedule. All the meetings in the state of Connecticut are in there. The hotline number is in there, and also ways to get a hold of us. I have 17 years of recovery, and I can attribute that mostly to Narcotics Anonymous. So it does work. Thank you.
I have just a brief question from people in recovery I've spoken to. For NA meetings, how do they, what's kind of the approach or whatever for people who are on medication-assisted treatment? Is that accepted within the NA framework?
You know, that's an outside issue. We have concepts, we have spiritual guidance through our concepts, and that's an outside issue. We really have no opinion on it. We're a program of abstinence from all drugs. You remember when you say you are, okay? So you're accepted at the meetings, absolutely. We believe in using no drugs. That may differ from some of the therapies. That it's not, it's not part of our thing.
Okay, so it's another tool in the toolbox.
You remember when you say you are, and anyone is welcome to come. And I went to my first meeting high, and we recommend you come back the next time not high. But whatever it takes, everyone's path is different.
Congratulations on your recovery. Thanks for your words, and we're glad that you got the book.
Good evening. I don't think this is going to be tall enough. So I'm Joe Gorman. I'm the Supervisor of Health and Physical Education. Mr. Mayor, thank you so much for this evening, okay? On behalf of the 18,000 plus students of our school district who fit the demographic of what we're talking about and don't. They don't fit the immediate demographic, but they live next door to those who do. They have relatives, they have cousins, they have uncles, they have fathers, they have mothers who get involved with this terrible scourge. And as Jennifer will always, we talk about this often, that the number one predictor is to have a family member who is a substance user. And it becomes a generational thing. So on behalf of the almost 19,000 school children in our district, number one, thank you. Number two, I want to issue a challenge to everybody in the room tonight to get involved, to help us bring your expertise out of the silos and bring them into the schools. And I stand ready to help in that way, in any way that I can at any time. So thank you for that.
It's down a little bit. Well, God makes no mistakes. It's ironic that I followed him because my name is Malisa Blasini. I've established a non-for-profit. It's called Free Them Foundation, and it's for youth of parents with addictions. The reason why I established this non-for-profit is because I come from a household where my parents were addicts. I have siblings who are addicts, and with the grace of God, I'm not. And I want to make sure that I make a difference for youth and their families, to make sure that they realize that this negative that they're enduring can be transformed into a positive. This can make them positive peer counselors and motivators and leaders in our communities, where they're open and receptive to situations and issues where other people who have not experienced this lifestyle can understand. The reason why I am up here is because I am so happy that this is going on, this awareness, and I am hoping and praying that whoever is listening can reach out to me and can help me make a difference in our community so we can make this nationwide, because in reality, our children are our future, and if we don't help them understand that everything that we go through is to prepare us for the next encounter in life, then they're not going to know how to take a negative situation and change it into something positive. So I want to thank everyone for coming out. I want to thank you for having me. And again, my name is Malisa Blasini, and the name of my foundation is Free Them Foundation.
Thank you. And Maria, can you please make sure that you signed in with the name of your organization? And maybe you can be involved in the task force afterwards. Thank you. Our next question.
My name is Leslie Gomez, and I am the facilitator and co-founder of the Woodbury Bethlehem Parent Connection, and we're a support group for parents who have kids who are addicts and suffering from addiction. My question is, and to, I guess, Robert and the insurance commissioner over here, is we have many parents who reach out to treatment centers who do not take insurance. And we have parents who are putting second mortgages on their houses, cashing in their 401ks just to try to get treatment for their kids. And they don't qualify for state aid, so they're really caught in the middle. The other thing I'd like to ask Robert is, how long do you think long-term treatment should be? 30 days, 60 days, a year? What is your thoughts on that? Because I had a daughter who got 7 days, and that was it twice. And once again, you talk about the dirty urine. They have to have that, so kids are going out and using just so they can get into treatment. And if they do have a clean urine, you can sit there for 12 hours waiting for insurance to clear you, and then they don't.
Yeah.
So that's a problem for our group is treatment solutions.
And I do hear that a lot. And I think in terms of how long should treatment be, my personal philosophy is as long as it takes for that individual, and not a day shorter. So for some people, it'll be short-term. For some people, it'll be long-term. There are programs out there that do take people without insurance. We have a sliding fee scale. I know there's lots of other programs in the area that do. I'm sure they're listed on the DMIS website as well. But I think that this is one of the reasons why this forum and whatever happens afterwards is so important, is we got to get the information out there to folks in terms of where they can go.
Right.
Not just for treatment, but also support for the family. And I applaud you, for what you do. I think that's a very, very important piece of it. But you're right. I've heard a lot of nightmares about insurance, and I have to put it out there simply because I feel like I'm not doing the subject justice if I don't. That we have a lot of folks that are coming into treatment that have gotten insurance recently through the health exchange and can't use it because the deductible is so high or their copay is so high that it makes more sense for them to go on our sliding fee scale for people who are uninsured.
And I know most of the people most of the parents in our group, the families, they have private insurance. And like you said, their deductibles are $10,000. And some of these private programs, and that's what it costs a month, between $7,000 and $10,000.
Yeah.
So I think it's a real problem for parents who do work hard and have insurance, only to find out when they really need it, it's not there.
Right.
So I think that's an issue.
I think Gerard maybe can comment from the insurance perspective.
Absolutely, and I think there's two issues, and again, the deductibles is a whole other issue that people need to be aware of when they're purchasing their plans, and to make sure that it's working best for them. But issues where they're getting denials by the insurance company, and the insurance company doesn't make medical decisions. Ultimately, again, it's the external review process, and it's an independent third party. So if you do run into those problems, don't accept what the insurance company is saying to you. Come to the insurance department, come to the Office of the Healthcare Advocate, use this pamphlet. It has a lot of great information on how to create the information that you need to get those treatments approved. So make sure that you're reaching out to the people that can help you, which is the insurance department, the Office of the Healthcare Advocate. And again, sitting down with an agent beforehand to understand your health insurance program is important for everybody. Again, those deductibles and those costs, that is because health care is very expensive as well. So that is an issue that everybody shares. The deductibles that we run into is just a portion of the way that health care is delivered in this country, and that's something that everybody here is trying to correct.
I appreciate that, and I'll take some pamphlets back to our group. So,
And just
thank
to
you.
comment, the lavender, and I think we have 2 more questions, and we're going to have to, because we're just about out of time. I think I have to limit it to the last 2. Bill, wherever you drew that line back there, it's like in the deli, last call. Just for anybody, any provider that's listed on this lavender sheet takes Title 19. They take pretty much all range of insurance. Many of them take a sliding scale. And for the lady who just asked that, nobody on here charges 10 grand a month, just so you know. All right, so if we could have these brief questions, brief responses, please.
I don't actually have a question. I just wanted to share that I know we were talking about the stigma related to addiction, and I do think that also prevents a lot of prevention efforts to share information. And thanks to Leslie, actually, I work with the local prevention council in Woodbury and Bethlehem, and we watched a viewing of The Anonymous People, and there's a website. It's a great documentary that talks a lot about advocacy and how people can join together to work with our legislators to make some changes affecting insurance companies and the face of addiction altogether. There's a website, Many Faces, One Voice. So I just wanted to mention that tonight. Thank you so much.
Thank you. Anonymous People is a great movie. One thing, before anybody else leaves, because we still have one more question, on your way out, Jennifer has a call to action, the mayor has a call to action. If you leave before they call that, if you're willing to be part of a follow-up task force, Jim outside's got a little magic marker. No further effort on your part, just put a little orange check next to your name and they'll find you. All right, our next question, please.
Hello, my name's George Dragon. Currently in recovery right now. I'm in the Suboxone program at Wellmore, and I am a resident at the Morris House Foundation. The question is, I've been there. Morris House Foundation's a 90-day program. I've been there for 90 days. Actually, next week will be 6 months. I'm not ready to go home. I don't have a support system. And I'm kind of, I'm scared to go. I just wish there was something else after this. And I just, maybe, something could be done about it. Because like they said, it takes a while for an addict, to get better.
Absolutely. And there is a lot of support that's out there in the community. And I think that it's a matter of making sure folks know about that. But certainly, afterwards, if you want to talk, I can point you in the right direction.
All right, perhaps afterwards, and congratulations on your continued work on your recovery. We're pretty much out of time. I'm going to ask Mayor O'Leary for our closing remarks.
Well, just to have some brief closing remarks, because I tell you, I was deeply touched by all the information that was distributed tonight, both here by the panelists and also by the members attending. Quickly want to thank the commissioners, of course, for taking the time to join us this evening. The folks from the state, as far as there was some very valuable information learned, I think, from the insurance side and also the advocate side. I could talk all night about this like Dr. Jacoby can. Honestly, when I joined the police department in 1980, heroin really was a drug that was mostly used by very, very poor people. And, we were focused a lot of attention on that back then. I'm so glad to hear Attorney John Davenport talk about the focus now really shifting to the dealers. It was always a focus, but, the addict, certainly the incarceration in Miss Early's case probably saved her life. Truthfully, I'd like to think that we have other alternatives now instead of incarceration that can assist an addict in recovery. The focus continues, I think, from the cop and me talking. I think we should really continue to go after the distributors and the drug dealers with everything we have to keep the pressure on them. At the end of the day, I wanted to hear from all of you tonight, and there's so many different points that have been spoken about, but I think awareness is probably one of the top three. I can tell you right now that I'm not sure that our parents in the city of Waterbury have a full understanding of what's happening here. I believe they don't. And I believe as leaders of the community, the superintendent of schools is here, our chief academic officer is here. You've heard Mr. Gorman, the tall guy, speak at the microphone. I think it's incumbent upon us now to start to develop curriculum opportunities, not only for our students, for our parents. And I believe our friend from Naugatuck Valley Community College is right. I think that, I don't know, in my mind, I keep thinking 5th grade is a good grade for everything, because that's when we used to do the DARE programs back in the day. But certainly, at a younger age-appropriate curriculum, I don't think would hurt us in the K on up level. But I believe what we'll get out of tonight, in addition to a strong recognition for curriculum development, is educating and starting to hold these forums. And I really don't care how many people come or don't come, but I think we probably should hold these forums on a monthly basis and start in our schools where it's easy for people to get access to, and really put the word out to our parents that I don't think they really do have any idea of what their children are faced with each and every day. You know, when I was a member of the school board in 2009, one of the biggest, I like to argue, but one of the biggest arguments I had was student surveys. You know, I'm a big proponent of student surveys. Members of the school board then and now, some are very much against student surveys, I think only because they're afraid of what they're going to find out. But the truth of the matter is, I think that we should start with a student survey, and the student survey doesn't have to be complicated. It can just be talking about what we're talking about here tonight, and let's get a real pulse on what's happening within the community in Waterbury and find out how many of our students are experimenting with opioid drugs, and by the way, every other drug as well. And I think we should do that, and then I think, Mr. Gorman and Superintendent Olet, then I think we need to make sure that our parents know what their students are exposed to. And I think that's going to be a very eye-opening event. And then to take you up on your challenge, I really do believe that together the education process is probably the thing that we as community leaders have the most control over, making a difference right away. So those are just some quick thoughts that I had. You know, we talk about overdose deaths. I think what doesn't get included in overdose deaths is suicide deaths. There's a lot of suicides that happen in this country that are a direct result of drug addiction and alcohol addiction, and mental health obviously is a major issue in that area as well. Before I forget, we have this whole meeting taped tonight. Anyone who would like a CD of this event tonight, by all means call Jennifer in my office and we'll give you a CD. You may be able to use it at anything that you're attending, whether it's a forum event, whether it's a family event, an educational event. We'll be sure to get that to you free of charge. And lastly, to Jennifer DeWitt, I just want to thank her because she's been doing this for so many years. And I really am looking forward to the future meetings that we're going to have. And I think they're going to be very informative. And, you know, I'm going to end by telling you this story. So back in, I think it was October or November, I got a call from Demas, who said to me that they were having a problem and a complaint from the city of New Haven. And the complaint went that there was a huge uptick in Waterbury residents and greater Waterbury area residents going down to their methadone programs down there because they were being told, the people in New Haven were being told that it's too crowded at the facility in Waterbury. So we did reach out to Connecticut Counseling, and they had acknowledged that there's been this enormous uptick in people looking for that type of treatment. And the numbers were staggering, really staggering. Like, you know, over the last 3 years, like 50 to 75% jump. I mean, today, currently, they service about 950 people. 950 people. And so we verified that this was in fact happening. And, you know, we've had conversations with Connecticut Counseling, and the city of Waterbury is and will be supporting the opening of a second clinic on the other side of Waterbury, so it'll be on the west side, and it will be, thankfully, thank God, because of all the not in my backyard people, thank God it's going to be on Brookside Road, which is not in anyone's backyard, thankfully. And I don't think we'll see a lot of opposition because the need is there. It's absolute need is there. And I thank all the other providers that are here tonight, Stay-Well, Wellmore, and everyone else. You know, we all, I guess, are at a point where we know that we are in this crisis. We're all in this together. We've got our first responders here. We've got our our ambulance personnel here. Police chief, fire chief, and everyone else is here. You know, I'm really very happy that the Republican American has covered this to the extent that they have. You know, the big, awareness for all of us who read the paper every day is shocking to see the amount of overdoses and deaths. And by the way, when I talked to you that heroin was the poor person's drug, when I went on the police department back in 1980, well, shockingly enough to me, throughout that career, we did start to see a huge influx of suburban kids from wealthy environments coming in and buying heroin on the streets of Waterbury, which of course the demand is increased and then the supply is increased along with it. And so I don't think that there's a police officer in Waterbury that hasn't come into contact with a child from Woodbury and Southbury and Bethlehem and Newtown and Thomaston and Woket. And it was shocking to us to see. And then, of course, once you drill down and figure out why they're there, almost all roads lead back to prescription drugs. So I think we have a handle on what's happening, but we certainly have a long way to go to try to address and fix the problem. But I think meetings like tonight are invaluable. And so thank you, all of you, for being here. Please stay in touch with us. Again, if you'd like to comment directly to us, you can do it through our website. We are going to set up a special task force. We're in the process now of asking participants to be involved. If you would like to be involved, I would like you to be involved. And so the next meeting will be on the 21st of April. You can contact Jennifer. Unfortunately, I will not be in state that day, but there will be plenty of subsequent meetings, I promise you. So thank you all very much for your time, and thank you, Janine.